Hello everyone, my name is Sayed Rashid. I'm a pharmacist at London Drugs Pharmacy. I'm also a student at University of Colorado's Cardiovascular Pharmacist. Today the topic of my presentation is the cardiovascular safety of Liraglutide. The reason why I choose this topic because this topic is really relevant to us as a practicing pharmacist. Most of the patients that we see on a daily basis are patients who have diabetes and who also have cardiovascular disease. So this is one of the reasons why I choose this topic, and I found it like you guys will learn something out of that too. So at the start of this presentation, the reason why I put this slide is that the cardiovascular risk is one of the biggest thing when it comes for patients who have diabetes. So these patients are at the highest risk of cardiovascular mortality, and it is estimated that up to 80% of patients who have diabetes will die from heart attack or stroke. So that is why it is considered one of the big things when it comes to diabetes and cardiovascular disease. Moreover, rosiglitazone, which is one of the anti-hypoglycemic medication, was found to be significantly increase the risk of myocardial infarction in patients with type 2 diabetes. So with this meta-analysis, Nielsen et al. Found that when we looking at the treatment for patients who have type 2 diabetes, we should not only focus on the A1C goals, we also have to look into the cardiovascular safety profile of the medication. And because of this meta-analysis, a lot of things have changed since then. Also, the result from Action to Control Cardiovascular Risk in Diabetes, or a CARD trial, has shown that lower A1C is not always good. Because what they did in this study, or in this trial, that they divided the group of patients in two groups. So one with an A1C goal of less than 6.5%, the other group was between 7 to 8%. And patients who were at less than 6.5% A1C goal, there was higher cardiovascular mortality in this group. In fact, they had to stop this trial earlier than they planned. So this is the basis of which FDA did a paradigm shift in their approach. Since 2008, FDA made it mandatory for any new anti-hypoglycemic medication to also show the cardiovascular safety as well. And what they decided that the drug will be tested on 4 major adverse cardiac events, also known as 4-point MACE. So those 4-point MACE are: number 1, death from cardiovascular causes; number 2, the known fatal myocardial infarction; number 3 is hospitalization due to unstable angina; and last one was stroke. So FDA will be looking on any new anti-hypoglycemic medication on these 4 major points of cardiovascular benefits or safety. Now we know that what they will be looking at. The next question is how they will be gauging it, how they will measure that. So the criteria for safety, as mentioned in this slide, is the minimum criteria is the non-inferiority criteria, which means that in the study in which the new anti-hypoglycemic drug has been compared with the placebo, the new anti-hypoglycemic drug did not cause or does not cause more harm compared to placebo. And more technical terms, the hazard ratio will be, the goal for hazard ratio for this kind of criteria is less than 1.3 and at 95% confidence interval. For any new anti-hypoglycemic medication to show this superiority versus placebo, or in other words, study medication reduces the harm as compared to placebo, when that will be considered superior drug versus placebo, and again in technical term, hazard ratio of less than 1 and at 95% confidence interval. So please remember this slide, as these are the basis of which leader trial that we will be discussing today is designed, or was designed, sorry. At this point, I would like to introduce our patient for today's presentation. So MT is a 55-year-old woman who have a history of obesity myocardial infarction and type 2 diabetes. Her A1C is 8.5% at this point, and she's also taking these medications. She's on ACE inhibitors, she's also on beta blocker, and she's also on high dose statin, low dose aspirin, and metformin 1000 milligram PO twice a day. This is the most typical patient that we see in our practice. So that's why I included a patient that is relevant to us or to our practice. This patient also have a history of hypoglycemia with the use of sulfonylureas such as glyburide, and she also had urinary tract infection with the use of empagliflozin. Now the question at this point, what are the other anti-hypoglycemic medication we can suggest for this patient at this point? Is liraglutide an appropriate choice for this patient? We will come back to this patient at the end of the presentation after we review the leader trial and liraglutide. So the learning objective of today's presentation is we will identify the first and the second line medication for the treatment of type 2 diabetes according to the Canadian Diabetes Association guideline. I will describe the mechanism of action of liraglutide. Also, I will discuss the indication, dosage, and the side effect of liraglutide. Last but not the least, we will review the cardiovascular safety of liraglutide as demonstrated in one of the clinical trials. So let's discuss first the Canadian Diabetes Association guideline target A1C. So in most of the type 2 diabetes patients, the target A1C is less than 7%. We are very well aware of this fact. Also, to reduce the risk of chronic kidney disease and retinopathy, Canadian Diabetes Association guidelines recommend the goal of less than 6.5%, but it comes with the risk of hypoglycemia. They also recommend in patients who have A1C above their target and who also have CVD, and they have tried initial pharmacotherapy. They recommend to add an anti-hypoglycemic medication with demonstrated cardiovascular benefit. In this slide, these are the list of anti-hypoglycemic medication that are indicated for type 2 diabetes. So the number one, our first line therapy, we have beganoids or metformin. This is the only drug in this class. The rest of the medication which are considered second line by Canadian Diabetes Association guideline, and they're listed here again. So number one is DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors, and so on and so forth. So on this slide, I mentioned some of the drugs that have shown the cardiovascular benefit in the trials. And there's only two groups of medication that are listed in this slide. There are other trials that are underway right now, but I just want to highlight this fact that liraglutide is not the only one that have proven cardiovascular benefit. There are other ones as well. So it's a semaglutide, which is again one of those GLP-1 agonists. Empagliflozin is SGLT2 inhibitors. Canagliflozin is again SGLT2 inhibitors. And last but not the least, the liraglutide, the leader trial that we will be focusing in today's presentation. Focus on liraglutide. So I would like to give a brief history of liraglutide in Canada. So liraglutide is the second GLP-1 agonist that was approved by Health Canada after exenatide in May of 2010. It is also approved by Health Canada in 2017 for proven results of the cardiovascular benefits after the leader trial. Indication and use. Liraglutide is only indicated for type 2 diabetes. It has demonstrated cardiovascular benefit, and it is not indicated for patients who have type 1 diabetes. Liraglutide can be considered to use with insulin or oral anti-hypoglycemic medication in type 2 diabetes as well. The mechanism of action of liraglutide, it has a very unique mechanism of action. We know that most of the drugs work on one point in the body to work as an anti-hypoglycemic. However, liraglutide works in different parts or different organs in our body. So it works on the pancreatic level, it works on the brain, it also works on the GI tract. So on the pancreatic level, liraglutide works by glucose-dependent insulin secretion. On the pancreas level, liraglutide reduces the inappropriate secretion of glucagon, and we all know that glucagon increases the blood sugar, so it decreases the secretion of glucagon. Liraglutide increases the beta cell growth and replication, which are again present in pancreas. Liraglutide decreases gastric emptying, so this is at the gastric level. And on the brain level, liraglutide reduces the food intake. Or this is just the diagram of what I just discussed in the previous slide. So again, on the brain level, it decreases food intake. On the pancreas level, liraglutide, which is a GLP-1 agonist, works by increasing insulin secretion and decreases glucagon secretion. And on the GI tract, it decreases gastric emptying. So I'm just gonna discuss what we have discussed so far. So we discussed why it is important for any new antihyperglycemic medications now to show the cardiovascular benefit. We discussed what are the goals or what are the target that A1C that Canadian Diabetes Association guidelines recommend. We discussed some of the drugs that have shown the cardiovascular benefits, and we just also discussed about the liraglutide mechanism of action and what it's indicated for. Now I'm just going to switch gears, and I'm just going to discuss in depth the LEADER trial, which is the groundbreaking trial of liraglutide effect and action in diabetes and evaluation of cardiovascular outcome. The goal of this trial was to evaluate the long-term effect of liraglutide on cardiovascular and other events that are clinically important. So liraglutide was indicated for type 2 diabetes. Before this trial, we just did not know how it can affect on the cardiovascular outcome. So that's the reason why this trial was designed. The study design, as you guys can see, it is a multi-center placebo-controlled randomized controlled trial. And again, the randomized controlled trial is considered the gold standard when it comes to study any medication. There was a total of 9,340 patients, and they were divided into two equally divided groups. And one was the liraglutide group, the other one was the placebo group. And it is considered one of the largest cardiovascular benefit trial, because no other trial have these many patients in one trial. Also, it's important to mention that it is a non-inferior study design with a pre-specified margin of HR less than 1.3. Remember, we discussed in slide number 3 that the criteria for safety for any drug, for any antihyperglycemic medication, the minimum criteria is that in the clinical trial, the drug should show the hazard ratio of less than 1.3, and they included in this trial of liraglutide. The major inclusion criteria, they included 81% patients who were over 50 years of age and already exist with a coexisting cardiovascular disease and type 2 diabetes with A1C of 7%. So in short, we can say that they really put this drug to test, because if you see the major population, the 81% already have cardiac event. They're already at risk. So they really want to test this drug now in terms of cardiovascular safety. The other group in this trial was that 19% patients were over 60 years of age with the risk of cardiovascular disease. The major exclusion criteria, they excluded anyone who had type 1 diabetes, because again, GLP-1 agonist is not recommended in patients with type 1 diabetes. They also excluded anyone who were using GLP-1 agonist before their randomization, and also anyone who were using the DPP-4 inhibitors. And the other exclusion criteria are listed on this slide. The intervention. So in the intervention group, the intervention group received liraglutide 1.8 milligrams. So they started this drug or liraglutide with the lowest possible dose of 0.6 milligram, and after a few days they increased to the maximum dose of 1.8 milligrams, as we see in the practice as well, that usually patients start at 0.6 milligram and then they slowly go up to the maximum dose. The placebo group just received the placebo drug in the injection form, and they just kept using their own medication that they were already on before the start of this trial. The outcome of the study was there were both primary and secondary outcome of the study. The primary outcome was in time to event analysis, the first case of cardiovascular death, known fatal MI or known fatal stroke. So this trial considered 3-point MACE. So remember I discussed a 4-point MACE, I think on the second slide when we were discussing about FDA requirement for cardiovascular safety. So this trial was looking at the 3-point MACE. And this is usually what happened. This is what most of the study design, the researcher used the 3-point MACE, and normally in the clinical trials. Also, in the secondary outcome, they were looking at the cardiovascular causes of death, hospitalization resulted from unstable angina or heart failure, and known fatal stroke, and coronary revascularization. The statistical analysis they used was time to event analysis, and the model they used was Cox proportional hazard model. The cardiovascular outcome was really interesting, and in this trial they followed patient for up to mean of 3.5 years. This trial actually lasted for up to 5 years, but they followed these patients for up to mean follow-up was 3.5 years. There were fewer patients who experienced primary composite outcome, and there was only 608 patients in the liraglutide group and 694 patients in the placebo group, and it was a reduction of 13% of the primary composite outcome. And again, remember the primary composite outcome, they were looking on 3-point MACE. So cardiovascular mortality, known fatal MI, and known fatal stroke. So in that, there was a reduction of 13%. And it was considered statistically significant and with a hazard ratio of 0.87. So remember when we discussed the criteria for safety, the minimum criteria they were aiming for was actually less than 1.3%. But this drug was actually proven superior because this drug proven that it is actually beneficial for the cardiovascular outcome versus placebo, both by the reduction of 13% and also the hazard ratio of 0.87 was also reduced. There were also fewer deaths due to cardiovascular reason in the liraglutide group, and it was 22% reduction in cardiovascular death. And again, the hazard ratio is even lower than the primary composite outcome, and it was actually 0.78. So again, in my second slide, in the first slide, I was discussing about how it's a big issue when it comes to cardiovascular mortality in patients with type 2 diabetes. So this drug is actually showing that it has improved, or it is better than the placebo when it comes to cardiovascular death or cardiovascular mortality. And again, I have to mention that it is clinically significant or statistically significant. Sorry. The other cardiovascular outcome was there were also fewer deaths for any other reason in the liraglutide group versus the placebo group. And again, there was a reduction of 15% in the interventional group versus the placebo group. The hazard ratio was 0.85. Is again less than 1. So it clearly shows there is a benefit with the use of liraglutide in terms of any cause of death. And again, it is statistically significant. Now, P is equal to 0.02. Last and not the least on this slide, there were a lower number of patients who had known fatal MI and known fatal stroke in the intervention group than the placebo group. This is just a graph of the outcome of the LEADER trial, or I should say the cardiovascular outcome of the LEADER trial. The primary outcome, as we discussed, that there were only 608 cases in the intervention group and 694 in the placebo group, and it just shows the hazard ratio of 0.87. Similarly, death from cardiovascular causes was also lower, 219 patients in the intervention group and 278 patients in the placebo group. and so as the death from any cause was also lower, clinically statistically significant, and has a ratio of 0.85. They also measured the microvascular outcome as well, and they found that there was a reduction of 16% in the intervention group versus the placebo group, where they has a ratio of 0.84, and again, it's statistically significant with P is equal to 0.02. The cardiovascular risk factor outcome, they found that liraglutide not only have the cardiovascular benefit, but it also proven that it able to reduce patient's weight of 2.3 kilogram higher weight loss in the liraglutide group versus the placebo group. There was also 1.2 millimeter Hg lower systolic blood pressure. However, there was 0.6 millimeter Hg higher diastolic blood pressure in the liraglutide group versus the placebo group. And also there was 3 beats per minute higher heart rate in liraglutide group versus placebo group. And hence we will see later in our presentation why it is recommended to monitor heart rate for patients who are on the who are taking liraglutide. This slide described the safety outcome of the LEADER trial. So there were more side effects in the intervention group compared to the placebo group. However, it was statistically non-significant with P value of 0.12. There was also non-significant overall higher rate of benign or malignant neoplasm in the group who received liraglutide compared to placebo. In this trial, liraglutide was associated with more pancreatic cancer versus placebo, and there were 13 patients who had pancreatic cancer in liraglutide group versus the 5 patients in the placebo group. There was also 23 patients who had acute pancreatitis as compared to 18 patients in the intervention group, and there were more cases of hypoglycemia there's less cases in the intervention group of just 114 patients versus the placebo who have 153 patients. So overall, if you see the safety profile of liraglutide, it can cause some pancreatic issues. So when we are counseling patients, again, we should tell them about the symptoms of pancreatitis. With this study, author concluded that the cardiovascular reason had a much lower rate of occurrence in the liraglutide group as compared to the placebo group, using time to event analysis. Also, there was less number of cases of non-fatal MI, non-fatal stroke, in the liraglutide group versus the placebo group in using time to event analysis. The limitation of this trial is that patients were only followed for up to 5 years, and some people think it's just not long enough time frame for following up for patient for safety. Similarly, they did not recruit anyone who have A1C of less than 7%. They also only included patients who have more than A1C more than 7%. So the question at this point arises that we cannot use this drug in patients less than 7% because they clearly not included those patients in this study. And lastly is that the study was funded by the manufacturer, so this is another limitation of this trial. The strengths of this study: this was a very well designed study. Patients were followed in intended treat analysis. Also, there was a large number of patients who completed this trial. So 97% of liraglutide group and 96% of the placebo group completed the trial, which is considered one of the strengths of this study. So at this point, this is pretty much the end of my covering the LEADER trial. From here on, I'll be talking more specifically more about liraglutide dosing and side effects profile. Dosing: liraglutide is recommended at the starting dose of 0.6 milligrams subcutaneously, and then it can be increased to 1.8 milligrams once daily. I think the biggest advantage with that patient starting at a lower dose, patient can tolerate that better, and once they get used to this drug, they can increase the dose to 1.8 milligrams, which is the target dose for this medication. Administration: it can only be administered by subcutaneously by subcutaneous route, either in upper arm, thigh, or abdomen. It cannot be administered by IM or IV route, and liraglutide can be administered with or without meal at any time of the day. The side effect profile. One of the most common side effects from liraglutide is headache, decreased appetite, vomiting, and constipation. But we have seen in the practice that a lot of patients comes back and then they complain about nausea and vomiting with the use of liraglutide. Monitoring, because it's an anti-hypoglycemic medication, so we have to monitor blood glucose, A1C, and also when we're counseling, we need to mention about the signs and symptoms of pancreatitis, which is one of the common side effects that was found in the study that we discussed today. So the signs and symptoms of pancreatitis can be upper abdominal pain, fever, or sharp pain after taking meals. So these are some of the signs and symptoms of pancreatitis we can discuss with patient when we are counseling them. And lastly, the heart rate as well, because there was an increase of 3 beats per minute, increased heart rate in the liraglutide group in the study. So they were also recommend to monitor heart rate when patient is starting this drug or is on this drug. The drug interaction, the most common drug interactions with liraglutide is with the sulfonylurea such as glyburide and the insulin, and with that it can cause hypoglycemia. And we generally are very good when we are adding any medication to metformin. We always discuss with patient about the signs and symptoms of hypoglycemia, but it is also good to mention that the liraglutide whenever patient starting this dose, and also on our other medications or on metformin. The place in therapy, the pros of this drug. So in the LEADER trial, we have witnessed that there is a cardiovascular benefit with the use of liraglutide, and we have seen that the result of LEADER trial is remarkable. So clearly, this drug have the cardiovascular benefits. It also lowers the weight of in doses used to treat type 2 diabetes. So it's a clear advantage because most of these patients are obese, and that's one of the reasons why they have diabetes, because they are obese. So with this, the same dose, you can achieve lower weight as well. So it's another advantage of using liraglutide. Also, it has once daily injection, so it is really good for patients who have compliance issue, because you just have to inject it once a day. The cons. Nausea and vomiting is one of the most common side effects we see in the practice. Patient always complains about that, or when they're starting this medication. Some people may not prefer injection, and generally speaking, it is a very big step for a patient who has been just on oral medication, have not tried any injection medication, and all of a sudden doctor introduced them to injection therapy. They usually think, oh my God, I don't know what's going to happen with me now. Now I'm on the last line of medications when talks about injection. So it's one of the cons of liraglutide. Lastly, it is not covered by Seniors Alberta Blue Cross, and it is a great disadvantage because this drug can be really beneficial for these patients who are over 65, because they usually come with the cardiovascular disease and type 2 diabetes. But unfortunately, because Blue Cross don't cover that, we cannot really recommend that drug for these patients. So here's a summary slide of what we discussed today. So number one, we discussed the Canadian Diabetes Association A1C goals of less than 7%, as was mentioned by them. Also, patients with A1C above target who have tried the initial pharmacotherapy, the second line medication should have anti-hypoglycemic, or second line medication for type 2 diabetes should have documented cardiovascular benefit. We discussed the first line pharmacological option in the Canadian Diabetes Association guideline, the second line of medications for type 2 diabetes. We discussed the mechanism of action of liraglutide, how it works. It works on 3 different points in the body. we discuss the cardiovascular benefits as was witnessed in the LEADER trial, and these are the summarized form of the result of LEADER trial. Now let's go back to our patient. Remember, we had a patient in I think the fourth or fifth slide that I introduced to you guys. So again, I'll just recap that patient. So MT is an obese patient who had myocardial infarction and also have type 2 diabetes with A1C greater than 8 or 8.5% A1C. Now she was also on metformin, 1,000 milligram twice a day. Now she required a second line therapy for the management of diabetes. So, do you guys consider that liraglutide is an appropriate choice in this patient?
Yeah.
Yes, it is an appropriate choice. Why? Because liraglutide has shown the cardiovascular safety profile. So clearly this patient needs that safety profile for any new antihypertensive medication. Liraglutide also have reduced weight. So this patient is obese. So we need a medication that will also help to reduce weight. Lastly, it is only once daily injection. Now this patient might have questioned about injecting a drug, but we as a pharmacist know how to counsel these patients. And when we discuss the benefit of this drug, I'm sure this patient will agree to use this drug and will be benefited from this too. So that's all for me. At this point, do you guys have any question, concern about the presentation I did?
In the trial there, for their inclusion criteria, they included patients with less than an A1C of 7%, or they excluded them rather.
Mm-hmm.
Did they give any reasons or particulars why they did that, or?
So they didn't give any reason why they excluded those patients.
Mm-hmm.
But what I think is, when you're going for less than 7% A1C goals, there is a higher risk of cardiovascular mortality.
Right.
So as we discussed ACCORD trial today, and clearly in that trial, there was clearly a higher risk of cardiovascular mortality in those patients. So I think that's the reason why they did not include those patients who have less than 7% A1C.
Kind of a balance to play in there. Yeah.
Pretty much, yeah.
I noticed that for the primary outcome and the secondary outcome, they included cardiovascular mortality, and I was just wondering why it was included in both the primary and the secondary outcome.
Yes.
So the primary outcome was a composite outcome. So in that outcome, they were looking cardiovascular mortality in combination with known fatal MI and known fatal stroke. So if a patient have one of those events, either known fatal MI, known fatal stroke, or cardiovascular mortality, any one of them, then it means the patient have reached their primary outcome. Whereas in the secondary outcome, they were only looking cardiovascular mortality individually. And that's why you notice that there were even lower rate of cardiovascular mortality in the second outcome or the secondary outcome of 22% reduction versus the 13% in the primary composite outcome. So that is why they included cardiovascular mortality both in the primary outcome and the secondary outcome as well. All right. Any other question, guys?
No, it's
great.
good presentation.
Awesome.
Perfect.
Thanks,
And this is
Naomi.
just a reference slide for your guys' reference. And thank you again for coming on the weekend.
Yeah, you betcha.
I cannot
Anytime.
appreciate that.
Excellent. Yeah, no.
Thank you.